Good afternoon, everybody. My name is Rafael Martin. I am the Vice President and Chief of Staff at the University of Texas at Dallas, and it's my pleasure to welcome you to this program that is jointly sponsored by the three University of Texas systems institutions in the Metroplex. And I'm very pleased to be joined by colleagues from all three institutions this afternoon for this program. First, from UT Southwestern Medical Center, we have Dr. Emily Adhikari, Assistant Professor in the Department of Obstetrics and Gynecology, and Dr. Reuben Arasaratnam, Assistant Professor of Internal Medicine and Infectious Diseases. From the University of Texas at Dallas, we have Dr. Timothy Bray, who is the Director of the Institute for Urban Policy Research. And from the University of Texas at Arlington, Dr. Aaron Carlson, Director of Graduate Health Programs, and Dr. Florence Hazeltine, Executive Director for Health Research and Presidential Distinguished Professor of Nursing. So welcome to our panelists, and thank you all for being here this afternoon. Without further delay, I'm going to ask Dr. Bray and Dr. Arasaratnam to give us a little bit of background information on where we stand currently in terms of the pandemic, and then we will get into some questions submitted by folks before this program started. And if you would like to submit questions for our panelists, please feel free to do so in the chat at any time. And I assure you we will try to get to them later in the program. So with that, I will turn the program over to Dr. Bray to give us an overview of the current state of the pandemic in North Texas. Dr. Bray.
Good afternoon, Dr. Martin, and thanks everybody for participating today. We are in a pretty good place, relatively speaking, to where we were a month ago. This is from our dashboard. New cases in North Texas in the last 7 days, 11,000, down from 23,000 just a week ago. Active cases at 47,000, down from 92,000 a week ago. And finally, the last metric that starts coming down is our deaths, and deaths are down slightly from the week before. Generally speaking, for Omicron, Dallas peaked on Tuesday, January 18th with 84,801 active cases. And by comparison, the Delta wave, which we had in the fall, peaked around 24,000 cases. So Omicron was roughly 4 times more widespread than in Dallas. Today, we've got 11,741 active cases in Dallas County. This is down 86% from our peak in January. So the rumors about Omicron hold true. It moved very fast through our community, much more contagious than Delta was, and infected many more people. The good news was the infections on average tended to be less severe. The dashboard also shows us where we're at with hospital capacity. Right now, we're at about 91% of our hospital beds occupied in North Texas, 93% of our ICU beds, and only about 33% of our ventilators. Even at the peak early on with the more severe infections, we never really hit more than 40 or 50% of our ventilators in use. Our Texas-wide positive testing rate is at 8.1%. So again, this is down from when we had the ravages of Omicron going through the community. So all in all, we are on our way down. I'll show one quick picture of this. This is the statewide trend chart. And you can see just how steep our active case decline in Texas has been. Our active cases are now down lower than they were when we peaked with Delta. And the same is true, by the way, with our new cases down here. So rapid rise, rapid decrease. But we have to continue to be vigilant if we want to see these numbers continue to go down. We got to make good choices. So, Dr. Martin, that's the numbers where they stand today.
Thank you, Dr. Bray. And also let me say thank you again for your work in developing this dashboard. It's been really instrumental for UT Dallas as an institution in our response to COVID-19. And I know a lot of local governments and other companies have been using it as well to help guide their response. Let's move on to Dr. Arasaratnam. If you would give us just kind of a brief overview of where we stand right now in terms of treatment and the medical perspective on the pandemic.
Well, good afternoon, everyone. It's great to be here. Thanks for having me here. And today, I just want to really focus a little bit on maybe a big picture view of Omicron and also just the importance of vaccines in this. So as shown by Dr. Bray, the rise and fall, right, of what we've seen. But I also want to put up this slide to just illustrate that this is not just a local problem, it's a global problem. And so we are going to have to think very carefully in this pandemic that we need global solutions. And as this pandemic evolved, our capabilities and technologies of actually picking up and detecting variants have been very, very important to our management. And so very, very early on in December, UT Southwestern were getting genotyping of these positive COVID-19 samples, picked up Omicron as becoming the dominant variant and now exclusive variant in North Texas. And as Dr. Bray eloquently showed, the news is good. Things are getting better with regards to cases, percent positivity of tests, and with hospitalizations. But I do want to take a little bit of time and pause and reflect on the impact of Omicron. Because yes, while studies have shown the severity of illness is less in some persons, really the cumulative burden of this wave has been huge. And I think we need to pause and reflect on that. 5 times as many cases compared to Delta and almost twice as many daily average hospitals. I don't really see anything mild about this. It has actually had a huge impact on our healthcare systems, huge impact on our staff, not just physically doing the work, but also the emotional toll and the burnout from that. And so even after Omicron subsides, we are going to be left with a lot of work to do to recover. Now, the onset of Omicron has kind of put yet again the impact of variants in our pandemic. And this is a teaching slide that they often just say we must expect variants in the pandemic because viruses do mutate over time. It's a very natural and expected phenomenon. It's been happening since the beginning of the pandemic. Now, the vast majority of those mutations may not be clinically relevant, but occasionally some of these variants impact the ability of the virus to spread, the severity of the disease, and can impact some of the therapies that we use, such as monoclonal antibody therapy. And there is a national genomic surveillance system that is in place that actively monitors variants on a day-to-day basis. And the thing to remember as we think about this, and as I alluded to the first slide, is that any ability for the virus to replicate is going to be an opportunity to develop variants. So it is a global problem, and every measure taken to slow the spread is going to be hugely impactful. Now, what about vaccines? As I'll allude to, the message is still the same, but with just more data. Despite the variants occurring, vaccines have still been an incredibly useful and preventative tool on a number of levels. This is data showing the impact of Omicron in New Yorkers. And the graphs here show the number of COVID-19 cases, hospitalizations, and deaths. And what you will see is that discordance between the unvaccinated and those who were vaccinated, just showing the power of vaccination in really preventing cases, hospitalization, and death. And there's a nuance to this vaccination because the booster dose has been shown to be critical. Even in Delta, here look at the middle column, we saw that the impact of a third dose, of a booster dose, was great in terms of active effectiveness against hospitalization. But we're seeing that against Omicron as well, that all-important booster dose. And why is that? Well, often we focus on levels of antibody, quantity, but the booster dose is not just about quantity, it's about quality. And actually, what ends up happening with the booster dose is not just higher antibody levels, but antibodies that can cross-react and cross-protect against the Omicron variant. And we've seen the studies done in the lab to show that. So the message I have about COVID-19 vaccines today is still very much the same, but with even more data. Over 550, almost 550 million doses given in the US. And we even have newer vaccine platforms in the coming year that we might see get approval. We have months and months of follow-up. lots of long-term follow-up showing not only the safety, but the effectiveness of these vaccines. We have 2 of our vaccines that have moved to full FDA approval, really reflective of that ability to monitor over several months and gather that data. And while these vaccines were studied in immune competent individuals and healthy adults, we actually now have a huge amount of data showing the excellent safety profile in lots of different populations: children, pregnant women, immunocompromised patients, such as solid organ transplants and bone marrow transplants. And so the message is, even with the variants, vaccines have been an incredibly useful tool against protection against severe disease, hospitalization, and death. And this map just really shows that there still remains pockets of our country that are not fully vaccinated, here shown in the orange. And vaccine eligibility is there for everyone age 5, booster shots for those 12 years and older. And then, as I'll explain in the next slide, a little bit of a nuance for those who are immunocompromised, who are actually eligible for an additional dose. So the booster is important. The only real reason to delay a booster is if you have received monoclonal antibody that can interfere with the ability of your body to produce a response to the vaccine, or you are having active COVID at that time. But if not in that category, this table really shows the recommendations for boosters and when to get it. Really, for the vast majority of the population that have received the mRNA vaccines, a booster at 5 months after your initial series. And for those who are immunocompromised, there's been a consideration that essentially these patients after 5 months should get a 4th dose, really reflecting that it takes time for their immune system, with either the procedures that they've received or the immunosuppressive medications that they're on, to build up that immunity. So at the beginning of this pandemic, we were understanding the structure of the virus. Within a year, we had safe and effective vaccines. And then 2 years on, we still have safe and effective vaccines that have even taken us through very severe waves and our most recent Omicron. I'd like to finish there and just also highlight a couple of very helpful resources that are great for answering some of the common questions that occur from UT Southwestern and the CDC. Under the UT Southwestern resource, there's a very helpful blog that's written by experts, lots of different topics about Omicron, pregnancy. These are great blogs to read, written by experts that really convey the latest data and help to inform the public. Thank you very much for listening. I look forward to the questions and discussion.
Thank you, Dr. Arasaratnam. A couple of questions have actually come in the chat related to your presentation, so I'll just go right to those. First from Andrea, is the Johnson & Johnson vaccine not recommended as a booster shot?
Yeah, so really what's happened now is the preference has gone towards the mRNA vaccines, so the Pfizer Moderna vaccines. And that's really based upon months and months of data looking at the different effectiveness of these vaccines and safety. And so we're looking at the mRNA vaccines as booster.
Okay. And from Barbara, she asked if you could expand on the booster providing cross-reactive antibodies or more variety of response, not just quantity of antibodies.
Yeah, thank you very much for that question. So essentially, studies in the lab can be done where you look at people who have received boosters and those who have not. And essentially you set up these studies in the lab to look at the ability of the antibodies produced by persons who have received vaccines in those 2 groups to neutralize Omicron virus. And what you see is not just the levels of antibody are higher with that booster, but actually the cross-reactivity against Omicron is higher as well. And that's just really just a marvelous function of the immune system, the ability to actually generate diverse antibody against diverse targets. But the data's showing that that booster really helps the immune system in doing that.
Thank you. And then lastly from Shauna, who says that she knows a few people who aren't getting the vaccine because of concerns about myocarditis, and I assume the same would be for other, potential risks. What do you suggest telling those people?
Yeah, that's a really great question. There's actually a study really coming, recently just came out, looking at that booster dose and the instance of myocarditis. And so this was based on the surveillance data. So many of you might know that after getting the vaccine, you can, register any symptoms you have with this V-Safe app, and there's other surveillance systems that the CDC have. And what this study actually showed is that with the booster dose, the incidence of myocarditis, even in the very, very high, in the highest risk group, which is typically young males 18 to 24, was incredibly low, less than 8 in a million. And this was lower than those who had received the second dose. And so the safety signals are just incredibly encouraging for the booster dose. Even those cases that do have myocarditis, and I'm talking about this is an exceptionally rare event, they are self-resolving and self-limited cases. And so I think concerns really should be allayed about the myocarditis risk, and I think clearly the safety signals there and the benefit of vaccines is clearly there too.
Very good. I see there's some other questions in the chat, but I do want to get to some questions for the other panelists here, and we'll try to come back, hopefully, if we have time later in the program. But this question is for Dr. Adhikari. Dr. Arasaratnam mentioned, the safety of vaccines for the population that you work with as an obstetrician gynecologist. What are you telling your patients about how to protect themselves and potentially their unborn children from COVID?
Well, I think the data on safety and now efficacy of the COVID vaccines, particularly the mRNA series, that is certainly the one that we've seen most commonly and have the most data on in pregnancy, is really, really encouraging. We have been recommending vaccination since it was recommended to the general population, because we knew that in pregnancy, the risks for severe illness from a respiratory infection are higher. And that is because in pregnancy, you see about a 20 to 30% reduction in some of the functional residual capacity of the lungs in the third trimester, and an increase in oxygen consumption, and anything that affects that, like a respiratory infection, can really put a woman at risk. The vaccine offers protection, and it is safe in pregnancy and efficacious in preventing both infection from a COVID exposure perspective, right? If you are vaccinated and pregnant, you are less likely to become infected when exposed to the virus. And it also protects against hospitalization. And so there's about 90 to 95% protection from the vaccine. It also offers protection to the fetus. And so there's a recent study out from the CDC that provides some preliminary data to suggest that maternal vaccination during pregnancy actually protects from infant hospitalization from COVID for infants less than 6 months old. And so that's really important data that we communicate to our patients.
Very good. Thank you very much. Dr. Bray, there's been a lot of misinformation surrounding COVID-19, surrounding treatments and vaccines for COVID-19. What do you recommend in terms of sources of information? Where should we look for trusted information on this topic?
Yeah, thanks for that question, Dr. Martin. I think one of the challenges is with any news about this pandemic, we get a lot of sensationalization. And then we get a lot of point counterpoint type arguments. And I tell my students the same thing. Go to your local public health official. Their website tells you what's going on. Go to trusted research sources like UT Southwestern. These folks are actually monitoring what's going on in our community. And particularly for our students, I tell them to go read the journal article. These articles, the abstracts are accessible to folks. They're not, you may not understand the particular method that they used, but you can see what the scientists themselves said the results were, right? And so, early on, when we had lots of conversation about, do masks work, do masks not work? And there was some question about, does a gaiter work? And somebody found a study that wasn't even meant to study this particular thing. And, it got blown out to the whole world as, oh, look at this, nothing works but this other type of device. I think the real challenge is not to take the clickbait on social media, right? That's really what we've got to do. See what the claim is and go investigate it for yourself. So CDC, FDA, local public health authorities, state public health authorities, and local research institutions like UT Southwestern that are actually doing the genomic data for what's happening in Dallas. I think if we confine ourselves to those sources, we will be better consumers of this information, and we'll stop passing on bad information to our friends.
Thank you, Dr. Bray. Dr. Carlson, as an expert in public health, you've seen kind of the trends, and that hopefully we're kind of through the Omicron surge, at least in the North Texas area. Hope is increasing that we'll be able to return to normality, although I've said that a couple of times already during this pandemic and have been disappointed both times. What do you see from a public health perspective, from an epidemiological perspective, is our future, and what do past pandemics teach us about what we should expect going forward?
Well, past pandemics teach us that we'll be learning a lot of lessons, which we already have, and that we'll gain a lot of knowledge that we'll be applying to the future. Also, that this will not be our last pandemic. So whether we are through this or not, this will not be the last time in most of our lifetimes that we face this. There's a lot of factors. There's a confluence of factors that made it highly likely that we were going to have a pandemic. And so it was not surprising to many of us in public health that there was a pandemic, and that there is a pandemic. And those factors have not gone away. Factors including increased globalization, climate change, all of these give rise to that help facilitate the spread of disease and give rise to new diseases. So this isn't going to be our last one. I also think that we should be very cautious in our optimism of how far through COVID we are. I'm very hopeful, as we all are, that soon enough this will be in our rearview mirror, but I think we already know that this is going to be endemic. This is now endemic, meaning it's not going away. This is part of life for us. But how serious the next variants are, the next wave of variants or variant, that remains to be seen. So we can be hopeful, but we need to have cautious optimism. Some things that can help make us more hopeful is taking precautions to mitigate transmission, such as vaccination, masks, and to not let our guard down too soon. Because the sooner we let our guard down, the more opportunity there will be for transmission. And every time you have transmission, that genome copies. And every time that genome copies, there's a risk of, well, there always is a little change, a little error that happens in the copy. The question is whether or not that little error or change that happens in the copy of that genome from one host to another leads to a variant of concern. Okay, so we have to be still very careful to try to mitigate spread and transmission of this disease so we can mitigate the possibility of a new variant that would cause us to have to go back to December when Omicron really hit and January and lay low again. And so let's everyone do their part. And if we can do that, then hopefully we can get through this. The other thing that will really depend is much bigger than the United States. We absolutely have to do our part, but this is global. And we know from every pandemic that happens globally, that's a new one. Locally happens globally or globally, if you want to create a new word out of it. And so what happens locally happens globally. So it is the responsibility of every community to hopefully mitigate transmission, mitigate spread, and take those precautions. So every one of us in the globe has some responsibility for that, as also a responsibility to help our global neighbors to have access to vaccines and all of those things. Because even if one country is very safe and if another isn't, or if one community is very safe and another community isn't, there still is opportunity for rise of a new variant. So it really takes the whole globe practicing these precautions so we can stop the spread and thus stop a new variant from possibly occurring.
Thank you, Dr. Carlson. Dr. Hazeltine, I know that you have been involved with testing for COVID-19 at UT Arlington, specifically with some of your athlete population. What have you learned about testing and testing protocols and their efficacy in identifying COVID-19 in a population? And can you talk a little bit about what lessons you may have learned about what we might be able to do, given that the federal government is now mailing out testing kits to households around the country? How do we best utilize that resource in order to as Dr. Carlson and Dr. Arasaratnam said, kind of help slow the spread of COVID-19 going forward?
Well, thank you very much for including me on the panel and the University of Texas at Arlington. We were involved with testing the members of the athletic department that were involved in collegiate competition. The NCAA, I always get the initials all mixed up, mandated that the athletes be tested 3 times a week. 2 of them had to be RT-PCR, and those were what we did. And the other could be antigen. And the academic year 2020 to 2021 demonstrated that if we tested on that regular basis and reported, we were able to isolate and quarantine, and it would not spread to other members of the team. The teams did get it, but they got it from outside sources. We had very few examples of intercollegiate problems. We also were able to keep our teams on the field, and we only missed 1 track meet. And that's pretty much of a record. If you look at Vanderbilt, they had to cancel their whole women's basketball season, and so did other universities. So what we learned is that by rapid testing, and we got most of our tests back within 24 hours, usually even the same day, because we took them in the morning and ran the tests in the afternoon. We were able to be very fast. We often many times we found people who were negative Monday, positive Wednesday. And as a result, they weren't symptomatic and they went into isolation immediately. The tracking was exceedingly good. This year, however, we only do the ones who are unvaccinated and only on a weekly basis. And as you know, Omicron spread throughout the whole population. A lot of our people got it. We did not use the same, I would consider high standards that were in place last year. And we've seen the results of that. Now, the thing that we learned that was critical is that we had to get the results back fast. It took us about 2 months to get to that stage, but once we were there so that we could get them back really within 24 hours max, and that was 90% of our tests, that we were able to protect our athletes fairly well. We had an example in September when the kids didn't take us seriously, where we did have a big uptick, and this was in 2020. And then we only had 1 other episode where 1 team, most of the members got it by 1 exposure. So we were very successful with that, but it required the following: constant attention to detail, making sure everybody got tested, reporting the results rapidly, and we had a wonderful contact team and a wonderful setup for quarantining people. I would say that this year it just has not been the same. And as you know, with Omicron, we suffered the same results. We're now down to not seeing positives. You asked me another question that was about testing kits. They're critical. All of us probably have them at home, and when we think we've got a cold or we got an allergy, we're testing ourselves. The problem with home testing, and this has been reported, is that we don't know the incidence now because people test at home, and we only can trust that because they're not reported, that they're taking precautions. And I think our athletes probably are. They're pretty in tune with this, but I do not know what the rest of the population is doing. But I will tell you, we have home testing kits, and we're testing sniffles more than one would assume. And I assume everybody else who's listening is also doing the same. Thank you.
Very good. Thank you very much. The next question I'd like to pose maybe to Dr. Adhikari and Dr. Arasaratnam, and again to you, Dr. Hazeltine. Dr. Arasaratnam mentioned in his presentation kind of the toll that this pandemic has taken on our healthcare workers, our clinicians. And maybe I'd just like to offer you the opportunity, the three of you, the opportunity to kind of expand on that a little bit, kind of what you've seen both for you personally and with your colleagues with whom you work, or your students that you teach, who are in that healthcare environment day in and day out, and what are your concerns and fears if this goes on much longer?
I can speak, I guess, first, if that's okay. This is Dr. Adhikari. I can speak from some personal experience, but also my experience as a healthcare worker in situations where both general population and our healthcare staff work and live in the population, right? When you go to work and find that you have very few nurses in the hospital who are not out with COVID, and many physicians who are having to call out because they got exposed or infected, you find that taking care of patients is a really hard thing to do. And so obstetric care, unlike some other care where scheduled surgeries in many cases can be rescheduled, but in obstetric care, that gets real dangerous real quick. You can't cancel a C-section or a delivery past a certain point before it gets pretty dangerous to the baby. And so we have to keep going, but being able to take care in the best way possible for our patients really gets dicey when we don't have enough healthcare workers. And that got pretty dicey during Omicron. I myself experienced COVID when my kids, who were both vaccinated, came home from school right before this recent freeze, and my son had a positive contact at school and started coughing that night. And so we tested him at home, as Dr. Hazeltine referred to. We tested him immediately. He was positive, and we put him in isolation. And my daughter got sick the very next day. We tested her. They got to isolate together, and then I started showing symptoms. And I had been vaccinated and boosted, and fortunately was mildly ill for a few days, but because we immediately identified our infections and isolated, both my husband and then my mother remained, who were both vaccinated and boosted, remained infection-free. And so we were able to isolate, but of course I couldn't go to work and take care of patients. My kids aren't going to school during that time. And so we were all mildly ill, but my main concern was not so much for our own illness, but actually because my mother needed to start treatment for cancer. And if I infected her, then her treatment would be delayed for some unknown amount of time. And that I could not handle. And so it's not really about me. It's not about, how sick I'm going to get. It's really about who I'm going to infect and the people around me. My husband is also a physician and takes care of kids who are immune compromised. If I gave it to him and he took it to work, who knows who could have got infected. So it's not really about me, right? It's about how I can protect the people around me and then the people that they are around from this infection.
Thank you, Dr. Arasaratnam. Dr. Hazeltine, do you have anything you would like to add?
Well, what was important for our laboratory, and we were working, as you can imagine, through the whole time, was that trying to keep us not getting sick. I mean, because if we got sick, we couldn't do the test. We'd have to close down the lab. And in fact, some of us did get it, but it was in a situation where we had backup and it was only one person at a time. And it did not cause a major problem, but we had to be tested constantly. And I think the big thing for us, as we weren't on the front line, really. So we didn't have the exhaustion that our previous speaker spoke about in OBGYN. I incidentally am an OBGYN, and I can only imagine how difficult that was. But you're worried all the time, are your tests accurate? Things like that. And so it put a different stressor on us because we're giving clinical service, but we're not doing clinical care. And so, there were times when we had to fix a coding in the database, things like that. So the stressors were exacerbated. They're always there in this type of thing, but they were just worse because you knew that people got really, really sick. So we were nothing compared to what they had in the hospital. And even so, we did experience, I would say, compared to everybody else on this conversation, minimal problems.
Thank you. Dr. Arasaratnam, anything you'd like to add?
I'd really just like to endorse what Dr. Adhikari and Dr. Hesitancy have said. Let's think about this more than just personal. Let's think about family members. Let's think about people beyond us. Increased hospitalization is not just about the impact of care on COVID-19. Several other diseases outside of COVID-19 are impacted by that. And that includes both preventative care in the outpatient setting as a primary care physician, but also acute emergencies and other procedures there. So, and then let's also just think about the emotional toll and healthcare worker burnout, which has been a documented phenomenon during the pandemic. And that includes a whole range of staff. So I'm glad we're having this discussion, and just to sort of iterate that, as I put in the presentation, for me, there's nothing mild about Omicron. It's had a huge cumulative burden and adverse impact on our healthcare systems.
Thank you. And I think I speak for everybody on this call, and for those of you who are also healthcare providers and healthcare workers on this call, thank you. We know this has been very, very difficult for you all, and we appreciate the service that you have put in during this difficult time. A question concerning, I'll direct to Dr. Bray and then ask other panelists if they have some additional information they'd like to share about the BA.2 Omicron variant, and whether we should be concerned, what we know about it. Is that going to be the source of the next surge that we should expect?
Yeah, I would suggest that's really more for a virologist. Again, though, thinking back to where we get our information, this was a news release that had a significant amount of sense of being sensationalized. One of the things to note is that a lot of the crisis was around being able to detect that it was Omicron, not detect that it was COVID. And so I do think one of my virologist colleagues would talk more about the subvariants that are starting to talk about.
Dr. Carlson, Dr. Arasaratnam, do you have anything you want to add?
We certainly, this is something that, of course, everyone is keeping their eye on, most certainly, because we have to understand that BA.2 variant is 30% more contagious than the original Omicron variant. So we are concerned. However, the vaccines are very effective against it, as far as we know so far. So we're not terribly concerned for those who are vaccinated. But where my concern personally would lay is with the healthcare system. If we could have one more increase, one more surge that our healthcare system could be facing in the United States in the near future, if this really takes hold, because it is so infectious. So that's something that we really have to keep an eye on. It very quickly overtook the original Omicron variant in South Africa and other countries. And then it like, even in areas of Western Europe as well, it did cause a subsequent Omicron surge due to this variant. After we got the levels back down, they went back up with this surge in some countries. So we want to not lift restrictions too soon to make sure that doesn't happen here.
Very good, thank you. Next question, set of questions I'd like to direct to Dr. Arasaratnam from Jenny and Jerry and Shilpa and Sedona and others in the chat concerning vaccinations. There's a variety of questions here, and I'll just kind of let you answer in whatever order you feel is most appropriate, Dr. Arasaratnam, but about when boosters are recommended, whether we should expect a general recommendation for a fourth shot or second booster. And also, if you could talk a little bit about where we stand with the one population we know that is not eligible for vaccination yet, children under 5 years old, and when we might expect that population to be able to receive a vaccine.
Yeah, thank you very much for all those questions. Maybe I'll just start. I'm not a pediatrician by training, but obviously sort of follow COVID-19 vaccination in all age groups. And we are, Pfizer has been working on a vaccine for under fives. There is a little bit of time needed to look at the optimal dosing schedule to induce the appropriate antibody levels for this. And, data for that is probably expected to be April or May time, with then potential emergency use authorization following. But just to allude to that question, it's a good reminder just to say that we really still have people that don't have the opportunity to get vaccinated, or in immunocompromised patients are sort of less likely to respond to vaccination. And that's a sort of bridge to the next point, is that the fourth dose at the moment is really reserved for immunocompromised patients. When we think about additional or second boosters, at this point in time, there is no recommendation. Could this change, in the next couple of months or years? Of course it can. And I think one of the things to just illustrate really with the previous question, and it's this, is that it's very challenging to predict and act and what's going to happen. We have a new sublineage BA2, and I think the right answer to that is that we can only really act sensibly with the information that we have today, and that for me is just really making sure that you've had your booster. And I would also kind of like to add and iterate Dr. Bray's point earlier, especially as we have new information coming out, is go to the primary data and read that literature, because when you think about reports of higher transmissibility of lineages, well, there's other factors that could impact that, right? Population dynamics, how they interact, masking, and then when you think about disease severity of lineages and how this impacts, well, that takes time to evolve. You really do need weeks to months of observations of data on that. So I would really re-emphasize the point from Dr. Bray is just as we hear new information, really critically assess it.
Thank you. The next question from Juliet in the chat, I think I'll direct to Dr. Adhikari first and then ask the other panelists to kind of weigh in. But Dr. Adhikari, you mentioned that you have school-age children, and Juliet's question has concerns about kind of lifting or pulling back of mask requirements in many of our public schools and schools kind of across the North Texas area. And what precautions we should still be taking for our children, both those that are eligible to be vaccinated and those that are not.
I speak to this as a parent, not as certainly not as a pediatrician, right? But I certainly think that it's pretty easy for my kids to continue wearing a mask, even though they've recovered from COVID. I don't suddenly rip their mask off and say, you're going scot-free, you're done. That's not the way I approach this. It's very easy for me to put on a mask every day when I come to work, and it's very easy for my kids to put on a mask when they go to school. And I don't want to give the impression that despite the fact that we are over COVID in my house, hopefully for the last only one and only time, that it was mild. It was a very uncomfortable illness for me. It's not a fun to feel that sick, and that is a milder infection than it could have been for me, right? Because I didn't have other more severe variants, and I was vaccinated and boosted when I got it. So all of those things contributed to the symptoms that I got, which were fortunately mild, but still very uncomfortable. For my kids, they also experienced mild symptoms, but this is not the last time we're going to see more COVID in the schools. And so for my particular school, I'm grateful that we still can wear masks and that many of the children still do wear masks, because I think that because of the more and more infectious variants that we sometimes see, one kid that goes to school with COVID can infect many more children if that one kid was not wearing a mask that day. And so it's about source control when you talk about masks. And so the one person who's infected, if they are not wearing a mask, they infect more kids or more other people around them than if they were wearing a mask and containing those droplets.
Thank you very much. The question of masks reminds me that the CDC recently changed recommendations on the types of masks that they recommend for prevention. And this is kind of open to the panel. I don't know who might want to comment on this, but can you talk a little bit about what the recommendations are currently, and maybe a little bit about the difference between N95, KN95, KF94 masks that are available and the levels of protection that various masks provide? Anyone want to volunteer?
I'm not sure that I can speak to all of those variations in masking. I will say that the recommendation for wearing an N95 in the healthcare setting changed with Omicron. Certainly at our hospital, it was recommended for interactions with patients in more settings than had previously been recommended. For example, previously we wore N95s, particularly for symptomatic patients in certain settings or with procedures that were high risk, that sort of thing. And with Omicron, they expanded that recommendation in our hospital setting, but that's more of an institutional practice. So I'll let others speak to the types of differences between a KN95 or an N95 and that sort of thing in other settings.
I have some visual aids. I have an entire pile of masks in my office at all times on my desk. So for anyone who would like to have visual aids here. So this is a KN95. This is what you see. When you see this, it has the nose wire, okay? And it goes around the ears. So what's different between the KN95 and the N95 is an N95 is going to strap around the back of your head because that gives it a closer fit. That's recommended in the healthcare setting, of course. Now, for those of us who are not in the healthcare setting, we can have a very, very good well-fitting mask that protects both ourselves and others in a KN95. Okay, they're more readily available to those of us who are not in the healthcare setting. Like I said, there's an ear strap. Now, as long as that mask has that nose wire, which the KN95 does, and it fits your face, so you're not have big gaps around your face, then you're still going to receive very good protection using a KN95 as opposed to an N95 mask. So another mask that we have is the KN94. That's some people call it the fish mask. I don't know. I don't see a fish. This is my preference for a mask. I wear this a lot. And this is the one that's like this. It straps around your ears also. But you see, there's a little bit of a difference here in how it fits your face, and there's a little more room for speaking. So this is my mask of preference if I'm going to be doing public speaking, if I'm going to be lecturing to my class, because and I'm asthmatic. So for those of us who maybe have some challenges breathing, you're going to have a little bit easier time catching your breath in this KN94 mask rather than the KN95. Now, the KN94 is 94 instead of 95 because it has only 4 levels of protection as opposed to 5 levels of protection. So that's something you do need to be aware of. So the KN95 or the N95 is going to have the greatest protection with regard to the layers in it. Now, does that make a tremendous amount of difference outside of an infectious disease setting? No. To add that additional layer, like if you're going to be on an airplane or in a crowd or something like that, if you're immunosuppressed, immunocompromised, like I am, then I simply add another mask, a medical mask on top of that KN94. And now I have the same level of protection as an N90, as a KN95. So those are some things to consider. Another thing to consider, ladies or people with smaller faces, be sure to get a mask that fits your face. The advantage of a KN94 is a lot of times you can order it by size, a small medium or a large extra large. And so you'll want to be sure to get a mask in that small or medium if you have a smaller face. Otherwise, you're going to have those gaps. It's very important that you have a nose wire and something that minimizes the gaps around your face, because it's that airflow through those gaps that really can expose us.
Thank you, Dr. Carlson. And just for information for our audience today, I can tell you that the federal government has started shipping N95 masks to pharmacies. In fact, I was offered some at my local pharmacy when I was picking up a prescription just the other day. So if you need an N95 mask, you should be able to go to your local pharmacy and simply ask for one, and they'll provide it to you free of charge. I'd like to talk a little bit and maybe direct this to Dr. Arasaratnam. There's been much discussion about long COVID and ongoing symptoms and comorbidities associated with folks who even have had mild cases of COVID. What do we know now about long COVID and other complications that may come from being infected?
Yeah, I think long COVID is going to remain one of those really challenging things to study in a proper scientific fashion. Because if you think about it, we are often trying to disentangle the impact of the virus itself, a hospitalization associated with the virus, and then sometimes in unfortunate cases, a intensive care unit hospitalization, which in itself is often associated with long-term effects. And so there are sort of very carefully nationally led prospective studies that are going to be ongoing about this, along with a lot of specialist centers that have developed programs to help patients recover from this. So the term you will hear is often PACS, so post-acute complications of COVID-19, and UT Southwestern actually has a recover program that helps people with COVID-19. Now, what do we know about vaccination, duration of illness? Intuitively, it really makes sense that those with milder illness and short-lived illness are probably less likely to get long COVID, and you'll see sort of observational studies coming out supporting that. And obviously that mild illness is often associated with vaccination, right? And so that's another strength of vaccination in this. But as I said, real true scientific study for this is a little challenging, and it's going to take time. But so far, signals are pointing towards, vaccination in not only just preventing infection, but giving a milder form of COVID-19 and reducing the risk of long COVID. I think in the chat, we just posted the COVID Recover program run at UT Southwestern for the participants on this call.
Dr. Arasaratnam, as a follow-up, I have a child who's a type 1 diabetic. Obviously, it was diagnosed long before COVID was on the scene, but there has been some discussion that there's been an increased incidence in diseases like type 1 diabetes that deal with the immune system. Is there any research that bears that out?
To my knowledge, I don't think we've had, I don't think we had enough time to sort of monitor for that. I haven't today. I can't sort of quote a study or back that up. Needless to say, I think we'll have to just wait. And again, it's a very challenging thing trying to distinguish something that might naturally be occurring without COVID versus something induced by COVID. So I think time will have to wait on that.
Thank you. Dr. Carlson, there's obviously been a lot of discussion about hesitancy, vaccine hesitancy in our population. What, from a public health perspective, have we learned about overcoming hesitancy in populations? What are the best strategies to utilize, and how do we compare with other countries that have faced kind of similar situations, and what have their outcomes been?
Yeah, thank you very much for that important question, Dr. Martin. So there's some really great research by Kaiser Family Foundation on this exact topic. They have something called the Vaccine Monitor. I encourage anyone who's interested in looking at those data to look at kff.org Vaccine Monitor. Google it, because it's a nonpartisan, it's non-governmental, it is a totally independent think tank that has very, very good science. And what's unique about their studies about vaccine hesitancy and vaccine uptake is they have a very robust sample, in that they oversample for some of our more vulnerable and marginalized populations who we don't always see included in other data samples, such as folks who use disposable phones, also racial ethnic minorities. They really oversample for those populations, so we have a really appropriate and truly representative sample. So what they found in the Vaccine Monitor, studying these data throughout COVID, is that 14 to 15% of folks who in December of 2020 said, I am absolutely not going to take the vaccine, is still the same 14 to 15% of folks today who said, I absolutely have not and will not take the vaccine. So we have to differentiate between anti-vax and vaccine hesitant. They're very, very different populations. So I want everybody to be clear on that. So those are the folks that definitely are not going to get vaccinated. Where we've seen a great deal of movement is in the vaccine hesitant population. The vaccine hesitant population, who we define as, I'm going to wait and see, I don't know about this. They were 39% were vaccine hesitant in December 2020. 4% are vaccine hesitant as of the end of January 2022. Those 35% who moved categories moved into the vaccinated category. So it's important that we differentiate anti-vax from vaccine hesitant. And that's where we in public health want to focus our efforts. And that's where we get the most bang for our efforts, is the most return on investment is in the vaccine hesitant group. We saw a great deal of vaccine hesitancy for very, very good reasons, particularly in our African American population, as well as our Latinx community. Right now, today, the vaccination rates between African American, Latinx, and non-Hispanic white are almost equal. So that gap has been really closed. Booster rates among Latinx and non-Hispanic white are almost identical also right now. So that gap has really closed. And the way that we've closed that gap in public health is really by using trusted messengers. We know that people are far more likely to act on health information, especially vaccine information, when it comes from one person who they trust, who they know and trust. So we've had to, in public health, really, really partner closely with our medical community, because our medical providers are key messengers, because people trust their family physician and their pediatrician. Also, community health workers, trusted stakeholders in the community who are lay healthcare providers, lay health information providers, lay health educators, and also trust that those individuals in their homes, there are going to be those people in one's own family who they really trust for that information. And so getting that information into the hands of people who can be that one messenger who is trusted in a community can really help to resolve and overcome some of those concerns that people have. So that's one thing we've really learned. The other thing we've really learned in public health is to really work on a message of harm reduction. And we know this is well demonstrated in the health behavior literature. This is not a new concept, but for some reason with COVID, we did not do a good job of this in public health. And that means that instead, harm reduction is to suggest that you do something in a safer method rather than a completely safe method. When you give somebody an absolute and absolutely do not do this, or you absolutely must do this, we know that people are much less likely to accept that information and act on it. But when you give somebody an option such as this is a safer approach, and that safety happens on a continuum of risk versus reward, people are more likely to apply at least some of that information. So that's something that we need to really go back and focus more on. Our COVID education is more focusing on harm reduction. Think about things on a continuum of risk instead of you absolutely should not do this. So that's something we've really kind of learned the hard way to re-embrace in public health messaging.
Thank you, Dr. Carlson. Dr. Hazeltine, there's a question from Rael, I hope I pronounced that correctly, about hesitancy amongst nursing and nurses and nursing students. Is there anything that you all are doing in the School of Nursing at UT Arlington to try to overcome that?
I'd like to say yes, but I actually don't know. We were somewhat isolated in taking care of the athletic population, but we did test people if they asked and wanted to come in. So as I said, I would like to say that we had an answer to that, and that of course they all followed all the rules or guidance, but I don't have any information on it, sorry.
That's okay, thank you. Well, I want to be cognizant of our time. I do have one more question, which I'm going to direct to Dr. Adhikari, and then I think I'm going to go around the panel and just ask people for any last thoughts or any last comments they'd like to provide to our audience this afternoon. Dr. Adhikari, there were some questions that were received before the program concerning fertility and impacts of either vaccination or having a positive case of COVID-19 and the impacts on fertility. What can you tell us about that?
Great question. So when you ask a question about fertility and COVID or vaccination, you kind of have to think through the process, right? So what affects fertility is probably most likely the antibodies that people think of as autoimmune antibodies that could affect the carrying of a pregnancy or successful pregnancy. And antibodies are the things that are active, right? The things that are direct function or response from the body against something. And so there's concern early on that maybe the antibodies elicited by either vaccination or a COVID infection could affect a pregnancy or attack the placenta. And that has actually been studied. The antibodies from either vaccination or COVID infection don't attach to the pregnancy or the placenta in the way that affects a fertility implantation, for example. And there's been studies of fertility cases where they track patients who undergo fertility procedures, that is implantation, for example, and there is no difference clinically in the outcomes of those pregnancies and those who have seropositivity detected by either vaccination or COVID infection. There's also no difference in terms of sperm parameters after vaccination or antibody detection. And so all of that data is very reassuring, and the Society for, or the American Association for Reproductive Medicine actually strongly recommends vaccination as soon as possible for couples who are undergoing fertility procedures or involved with fertility specialists. The one caveat that I will say to this is when you think about what affects fertility, you have to think about the severity of illness after an infection, because those things really affect a woman's long-term health. And so not vaccination per se, but the infection itself in a patient who becomes severe or critically ill and is in the ICU and has a lot of complications, medical complications that result from a severe COVID-19 illness, that can affect fertility and the potential to carry a future pregnancy. Lung function, heart function, kidney function, those sorts of things. It is major and life-changing for those women who have unfortunately been severely affected. And so it's not a short list, those that we have followed for severe illness, but I don't know what to tell you other than vaccination is very protective against severe illness. And so there's no evidence for concerns of fertility after vaccination.
Very good. Thank you very much. Well, as I mentioned, I'd like to just go around to the panelists and ask them for any final thoughts. And we'll start with Dr. Bray. Tim.
Yeah, thanks, Raphael. So, my final parting thought is we need to, as consumers of this information, relax and not react. I think it's far too easy when the news first comes out. We're quick to report how quickly there's a new variant and should we be afraid? Let the science tackle the problem and trust the science. That means we've got to slow down. We've got to dig into the data ourselves. But most importantly, we need to not react and not spread more false information, right? We ourselves can be a part of that when we like or forward things. So, take a breath. We will get through this eventually, right? And we will emerge into a new normal that's not the normal we knew before. But the more we overreact, the more we can make things worse.
Thank you, Dr. Bray. Dr. Hazeltine.
There's not much for us to say, except we'll continue to test. We'll hopefully keep our tests accurate enough so that we pick up the new variants. We haven't had any trouble with that. But I hope that soon we'll be out of business.
Thank you. Dr. Adhikari.
I think the last bit of scientific information that I would share that we hadn't gotten a chance to address is really the effect of COVID-19 on stillbirth. That has been recently highlighted by the CDC and then by additional investigators who have looked at how COVID affects the placenta. And we know that stillbirth is extremely rare, so that means it's really hard to study. There was a question that was put forth before the panel that was about stillbirth related to the vaccine. And I'd like to make sure that that gets corrected, because there is no association between vaccination and stillbirth. There appears to be an association between COVID-19 infection and stillbirth in rare cases. And it has to do with COVID affecting the placental function and causing overwhelming inflammation in the placenta to the effect that the placenta stops working and fails to deliver oxygen and blood to the fetus. And that is a rare event, but it can happen following infection, not vaccination. Thank you.
Thank you, Dr. Adhikari. Dr. Carlson.
Thank you for the opportunity to one last round here. The message that I would love to leave with those who are listening and viewing today is we all have a responsibility to protect our most vulnerable. And we have a great example right here on our panel with Dr. Adhikari, wanting to protect her mom so she get the treatment she needs. Many of us are in some type of situation like that. So this is not a problem for somebody else to deal with. There are over 10 million Americans who are immunocompromised, either because of HIV or a genetic condition that actually impacts their immunity, or because they have an autoimmune disease that requires immunosuppressive medication so they can function. And for that reason, no matter what we do, those of us who are in that category, no matter what we do with regard to keeping with our vaccines and boosters, we cannot launch the same immune response against COVID or really many other things if we get ill. So it makes us a lot sicker. And then we rely on others. And so please know that it's not just some other group. You don't know who's around you, who's medically vulnerable. It's an invisible disability. We look and talk like everybody else, but our lives are very different. And so everybody has a responsibility, just as we have put in ramps and we have put in accessibility buttons and we have made it so screen readers, so hopefully those with visible disabilities can work and function well in the world. We need to now have a same approach with protecting our most medically vulnerable and keeping them from contracting a disease and keeping their loved ones from being worried about them in the ICU. Protect those families. Thank you.
Thank you, Dr. Carlson. And last but not least, Dr. Arasaratnam.
I'd like to really echo sentiments of what everyone has said and also thank the participants today. I'd like to finish with a final reminder that this is also, unfortunately, a pandemic of inequalities. And, you know, we've seen differences in access to therapy, treatment, and outcomes, both globally, racial disproportionality. And I think it's just a reminder, along with what Dr. Carlson says, is that, you know, the decisions we make on a personal level, but also on a public level, have to really take into account the other person and the vulnerable person. And so I hope that, you know, today's session has been helpful with that.
Thank you, Dr. Arasaratnam. Well, it's been a pleasure serving as the moderator. Thank you to all of our panelists who contributed so much information and wisdom here today. I also want to thank our community partners, the North Dallas Chamber, the City of Richardson, and Dallas College for their support and promotion of this event. And I want to thank you all for spending a little time with us this afternoon. I hope that it demonstrates some of the value that the University of Texas and the University of Texas system institutions in the North Texas area bring beyond simply providing medical services and educational services. The expertise that you see here today, you know, is possible because we have these institutions in the North Texas area, and hopefully you found it enlightening and valuable. So thank you again, and we'll see you next time. Bye-bye.